Hi, my name is Joshua Breger, and I'm a clinical faculty member here at Arizona State University. Before starting here in July, I was a speech-language pathologist in a Level 1 trauma hospital here in Phoenix, Arizona. I am a specialist in dysphagia, including advanced training in modified barium swallow studies and flexible endoscopic evaluation of swallowing, or FEES studies. I'm very excited to present my specialty, my passion in speech-language pathology, which is dysphagia. So let's talk about what is dysphagia. Before looking at this definition, many others have a shorter definition, such as difficulty swallowing. And although that is the definition of dysphagia, I prefer a little bit longer one, and this one from Tanner sums it up really well. He says that it is an impairment of the emotional, cognitive, sensory, and/or motor acts involved with transferring a substance from the mouth to stomach, resulting in failure to maintain hydration and nutrition, and posing a risk of choking and aspiration. And it's a mouthful for sure, but I really like the fact that he puts in the emotional and cognitive aspect, because that is such a huge part of what swallowing is. And if you do have an impairment, including the emotional and cognitive aspect, you can still have dysphagia. So why do we eat? I posed this question to my class this past semester, and it is so much more than just getting nutrition and hydration. That is a big piece of it for sure, but if you take a moment to think of how you would be impacted if you were on a pureed texture diet and you had to drink thickened liquids, how would that change your life? My students said that they would go out less, that they would be embarrassed to eat and drink in front of other people, that it would cause some social isolation. And we'll talk about that a little bit on the next slide. But if you just take a moment to think, it really does impact a huge part of your life. So here are the other impacts of dysphagia. We talked about some of the social isolation and the fear of eating, drinking, which are in that psychosocial aspect of dysphagia. This also can lead to a lack of self-confidence, some hopelessness, or even anxiety or panic. And of course, that it can all lead to a decreased quality of life. On the medical side of things, there are some obvious concerns such as aspiration pneumonia or choking and airway obstruction. With aspiration pneumonia, if something gets into the lungs, it can cause an infection, make a person really sick, or even die. Other things like difficulty receiving medication is something that is not thought of that frequently. But if you are having difficulty eating or drinking, if you can't get your medication in, that can cause other impacts on other health aspects of your life. Similarly, if you don't get enough nutrition and hydration, it can weaken your immune system, and that can cause infection and other negative aspects to your health. And finally, there's a financial impact of dysphagia. This impact is realized at the hospital and community level, with over 40% increase in hospital costs with somebody just with a diagnosis of dysphagia. It can also increase the costs to that individual and family members. Here's a short video showing the impacts of dysphagia on a single person's life.
I need to be.
When you can swallow, you have the luxury of wondering what you're going to wear, what you're going to eat, how pissed off you are that there's traffic on the way to work, and why the dry cleaners charge so much money for a shirt. You get to wonder about all that when you can swallow. But when you can't swallow, all you get to think about is that you can't swallow.
I will show you everything that you need to see.
I didn't eat anything by mouth for 6 years. I could eat Then I couldn't eat, and I had to learn how to be in the world and not eat. So you go from, grabbing an apple, salad, water, cheeseburger, whatever your thing is. You're just eating, and it just stops. Just like one day it just stops. You have a can of, it looks like liquid plastic, and you're just 7 times a day. Are you kidding? Really?
Let me close my eyes.
Not only are you not eating, but you're not going out for coffee, you're not making breakfast, you're not shopping, you're not preparing food, it's over. It stops. I would just get in a loop of frustration and anger and rage, which sounds not very attractive, but it's true. I mean, I just felt like, I guess it's like feeling sorry maybe for yourself sometimes. I would just get in that moment where I just thought, I can't be strong, I can't be positive, I can't be hopeful, I can't be, bigger than this, I can't make meaning out of this. I don't care. I just think something really bad happened to me, and I hate it. I thought there's got to be a second chapter, and I don't know what that looks like. I don't know what my recovery is going to look like. I don't know if I'll ever swallow again, but this story has got to have a different ending. And I remember the first time I was in public and I could eat something. People were walking around, there were benches, and there was a cafe, and I think I got, a muffin or something. And I remember it was kind of crowded, and there were people, and I sat on this bench, and I was like in public, in the daylight, not alone, not in my kitchen, not spitting in a cup, not pining for food at a table with friends eating. I had food, and I was in public, but yet I was anonymous. I took like this really teeny bite, and I had this straw, and I was lying down, but I thought, I'm in the world. It was like a moment where I thought, I'm back into the world. People are suffering, and people are brave, and they're not suffering in vain. They're suffering in a valiant attempt to have some dignity and some meaning to a life that's been radically altered.
So as you saw in the video, this is someone who could not eat for 6 years, and what a huge impact that had on her life. And when you go back to eating from after such a long time not being able to eat, it really can be a change. So let's look at some anatomy, and we'll go through this pretty quickly. But this is the sagittal view, or the side view of the face and the neck. You have your lips, your teeth, your tongue, hard and soft palate. And then this is the epiglottis. This is what's going to fold over and help protect the airway. These are where your vocal folds are, or your vocal cords. And this is your airway. And right behind that is the esophagus, or the food pipe. And so you can tell, or you can see how this could be a very precarious situation, that you have food and liquid going here. And if this does not shut off properly, and we'll see a few videos showing that later, food and liquid can go right into the airway instead of going down the esophagus. This is what it looks like on an X-ray or a modified barium swallow. Again, the lips, the teeth, the epiglottis right here, it's a little hard to see. You have the trachea, and you have the esophagus right here. This is a different view of the larynx or the airway. This is looking down from the nasal cavity onto the larynx from a flexible endoscopic evaluation of swallowing viewpoint, or a FEES. You can see the vocal folds and the epiglottis again, which folds over to protect this airway. The esophagus is actually sitting right behind this. In its resting state, it is closed. When food goes through the mouth and through the pharynx, it relaxes and opens up, which we will see a little bit later. And this is the live shot from it. Again, the epiglottis, the vocal folds or vocal cords, and we'll see these are the arytenoid cartilages, and when we swallow, these two come together to help protect that airway. So let's talk about the normal swallow. What does it look like when we swallow? We're going to go through this in 5 different stages. The first stage is called the pre-oral stage, and we say that we eat with our eyes first, and that is very true. We know that visual stimuli alters the perception of taste, smell, and even flavor. When we see something that looks like this, our mouths might water. We start thinking about the act of eating, and that just gets us ready to eat and drink. Why is that important? Well, when we prescribe puree texture, that can affect the desire to eat and drink. And so these 2 images are both of puree texture foods. Nowadays, we have what are called food molds that shape the food to look like the things that they actually are. And so you'll see mashed potatoes, peas, carrots, sausage, gravy. These might be the same things, but you don't know what they are. And so studies have shown that people eat more when their food looks like what it is supposed to be, even if it is a puree texture. The second stage is called the oral preparatory stage. This is a voluntary stage where we actually put the food in our mouth. Our saliva mixes with that food, makes it moist. We chew if needed, and we have bolus, otherwise known as just the food or liquid. We keep that together with using our cheeks and our tongue, unless you're this guy down here. The third stage is the oral propulsive stage. This is when we start getting ready to push that food back in our mouth after it's been chewed, if it needed to be. The tongue tip elevates, the sides of the tongue elevate, and we start pushing that food back towards our throat. Once it gets to the back of the tongue, we have posterior lingual propulsion, otherwise known as pushing the food back with the back of our tongue. This creates a sensory trigger once it gets back to the back part of our throat or the posterior pharyngeal wall. It sends a trigger up to the brainstem, which then initiates the pharyngeal stage of the swallow, which is next. So the pharyngeal stage, where the other stages were more voluntary, this is a rapid sequence of involuntary movements. So that trigger gets sent to the brainstem, and then it sets off a reflex back down to the muscles. This reflex lasts about 1 second from the food getting to the back of the throat until it gets into the esophagus. It is about 1 second long. And one of the main aspects of the pharyngeal stage is airway protection. Again, we saw how closely related the airway, the trachea, was to the esophagus. We really need to protect that airway to keep the swallow safe. So what happens in the pharyngeal stage? There's a lot of things here, and we're going to go through them, but we should note that the pharyngeal stage happens almost at the same time. So all of these happen almost simultaneously. Although we'll go through them in order again, they don't happen in this exact order. So first we have velopharyngeal closure. This soft palate raises to contact that posterior pharyngeal wall or the back of the throat. This shuts off the throat from the nasal cavity so we don't have stuff coming out of our nose. We already talked about that back of the tongue propelling that food or liquid into the pharynx or the throat. The hyoid bone is has a very important movement. It goes up and out. This does a few things. This helps raise the airway, the larynx, up towards safety, and also helps invert the epiglottis to cover the airway. The larynx and the pharynx elevate. Again, this is done partially by movement of the hyoid bone and also some of the other muscles in the throat. That epiglottis moves over to cover this airway, and the vocal folds come together again as another added layer to protect the airway from that food and liquid going down. The pharyngeal constrictions. We have three constrictors: superior, middle, and inferior, and they fire in that order to help propel the bolus down into the esophagus. So starting from the top, middle, down, it helps push that food down into the esophagus. And lastly, the pharyngoesophageal segment, which is the segment that separates the throat from the esophagus. That opens up and lets the bolus pass through. So again, all these happen almost simultaneously, and they're all involuntary. So talking about airway protection, when we swallow, we stop breathing. We call that the cessation of respiration. That can last anywhere from 0.75 to 1.25 seconds on average. We talked about how the arytenoids start moving together to help shut off this airway. They also tilt, as you can see here, they go in and go towards the epiglottis to make this airway as small as possible. Then the epiglottis folds over this airway to deflect the bolus to either side of it or over top of it. And then as an added layer of protection, we take a short exhale when we swallow, or before we swallow, and then after the swallow, we exhale again. So if you'd like to try that, it's not universal, but it happens more often than not. So when you take a sip or a bite of something, you swallow, you let a little bit of air out, you swallow that food or liquid, and then you let the rest of the breath out. This helps out because if there was anything on the vocal cords, that final exhalation helps push that food and liquid out into the surrounding safety areas. The last stage, that fifth stage, is the esophageal stage. So after it goes through the pharyngoesophageal segment, that segment that separates the pharynx from the esophagus, it travels down a 10-inch long tube from the throat to the stomach. There's one or two waves that are also involuntary. There's said to be a primary wave that pushes the food and liquid down. If it's a more solid bolus, there's also a secondary wave that can come afterwards and finish pushing the rest of the food down. Now let's take a look at some normal swallows. The first one from a modified barium swallow study, the second from a FEES study. And this is going to go really quickly. Again, 1 second from here to here. And in this case, probably less than a second. All right, let's back up and watch it in slow-mo. So for reference, this is that hyoid bone that's going to go up and out, helping this epiglottis fold over this airway. The vocal cords are right around here, leading into the trachea, and the esophagus is immediately behind it. Let's watch this spoonful of thin liquid. And seeing that larynx go up and down and that epiglottis folding over. We'll watch one more swallow in this slow-mo. And you see it fold over right there. It's currently protecting the airway so nothing's getting in there. Awesome. Let's take a look at a FEES study. Again, this is a normal swallow. So going through the nose.
Okay, so we've got the soft palate. Can you say dunna, dunna, dunna?
Dunna, dunna, dunna.
Lovely. And again?
Dunna, dunna, dunna.
And can you swallow? Great. So we're going into the pharynx. Lovely. All right, can you say E?
E.
Fantastic. Can you count up to 5?
1, 2, 3, 4, 5.
All right, how does it feel like in your throat?
It feels fine. I can feel it more in my nose, but not in my actual throat.
Okay, so we can see the vocal cords coming in and out. Can you laugh? And can you swallow? Lovely, we saw the epiglottis moving there. So, would you like to have a drink of the smoothie?
Yeah.
Lovely, so we saw a tiny bit of green, but it's all clear afterwards. Can you take several swallows in a row? Great, fantastic.
And you can see there, and once we hit play again, you'll see that epiglottis spring back up from protecting that airway.
All right, you fancy some chocolate?
Yeah, sure do. I can't actually see. Is that right?
Yeah, that's fine. Right, another bit. Right, you'll be glad to know you've got a completely normal swallow.
All right, so those are 2 normal swallows from 2 different types of studies. So what causes dysphagia? Many people know of the common reasons of dysphagia, one of being the cerebrovascular accident, or CVA, otherwise known as a stroke. And CVAs definitely have a high prevalence of dysphagia, which can be up to 50% in newer strokes. Thankfully, as people heal from the stroke, their swallow also tends to heal, but some people still need therapy and some people never fully recover their swallow function, unfortunately. Similarly, other neurological and/or muscle diseases. This is by no means a full list of those diseases, but Parkinson's disease, ALS, dementia, and that's one that many people don't really associate with having dysphagia, but in advanced dementia or even the middle stages of dementia, people start to lose their chewing ability, and that's one of the first stages to go, that oral stage. Brain or spinal cord injuries, of course, can impact swallow function depending on their level. Trauma. Some people after car accidents have to have their jaw wired shut. What can they eat or drink after that? And if they have a concussion, sometimes the cognitive aspect, like we saw in the beginning slides, that if there's a cognitive impairment, that can actually cause dysphagia. So there is a relatively high prevalence of dysphagia with somebody with a concussion or a traumatic brain injury. And thankfully, those heal up pretty well from a swallowing standpoint. Oral and pharyngeal cancer can definitely impact swallow function. And some of the rest of these may not scream out dysphagia when you first hear them, like respiratory disorders. But we see in respiratory disorders that since there is such a strong relationship between swallowing and breathing, since again, those two pipes, the trachea and the esophagus, are so close together, that if we have difficulty breathing, we may have difficulty swallowing as well. And also, if you think of that apneic period, that we stop breathing for up to 1.25 seconds, if we're eating a meal, we're stopping that breath over and over again. If somebody has a respiratory deficit, that can exacerbate things and then make that swallowing worse. Of course, structural abnormalities, if there is something structurally wrong in your mouth, in your throat, in your esophagus that causes the food or liquid to get hung up or stuck, that can cause dysphagia. Medications, if you ever have listened to a commercial for medications, some of the side effects will include swallowing disorders or swallowing difficulty. And infections, similar to cognition, infections can cause confusion, which then in turn can cause some difficulty with the swallowing function. Again, this list is by no means an extensive list. I didn't put on here cardiac difficulties or cardiac surgery. There is a nerve that is very important for swallowing that actually goes from the brain, wraps around the aorta of the heart, and goes back up to the muscles of the larynx. So it's the muscles that actually close the airway, the vocal folds, the arytenoids. And so sometimes if during cardiac surgery or after cardiac surgery, if that nerve was nicked or compressed, it can actually cause difficulties sealing that airway off. So we talked about dysphagia, what it is, how it can impact individuals. Now, what is our role as speech-language pathologists in dysphagia? So we kind of started around the 1940s, and we were really working with speech articulation disorders. By 1985, 35% of speech-language pathologists are working with dysphagia. And 1999, 47% of SLPs are working with dysphagia. And today it is a much higher percentage. I couldn't find the exact percentage, but definitely much more than 50%. And as in the 1940s, we really were not that involved at all with swallowing. Now we are, and this is perfectly stated by Rower and Crary, that said, "Today, speech-language pathologists have assumed a leadership role in providing care to children and adults with oral pharyngeal dysphagia." And this is very important because this is a relatively new subspecialty in speech-language pathology, and it's growing on a yearly basis, our knowledge base, our research base, and so it's a very exciting time to be in this field, and especially a dysphagia specialist. In this section, we're going to be talking about what we as speech-language pathologists can do to diagnose dysphagia and how we treat those swallowing disorders. When we first receive a referral from a physician, we complete what is called a clinical swallow evaluation, or CSE. We go to the patient's room and give them things to eat and drink. We observe their cognition. Are they able to participate? Are they alert enough to eat and drink? And we also observe the swallow. Are they showing any signs of possible aspiration, such as coughing or a gurgly vocal quality? If they are, We then proceed to what's called an instrumental assessment, and these are a couple of diagnostic tests that we have available to us, typically in the hospital setting, but they are becoming much more readily available in other settings as well. The first one we'll talk about is the video fluoroscopic swallow study, or VFSS, also known as the Modified Barium Swallow Study, or MBS. Those two terms are interchangeable, and it depends whatever setting you're in that different people call them different things. This is where the patient sits in front of an x-ray machine, and usually the radiologist or the radiology assistant will man the video camera, the x-ray machine. And the speech pathologist will give the patient different textures and consistencies to eat and drink, and will watch it go down on the screen. And we'll be watching a couple of videos of this in just a moment. The next test is called the Flexible Endoscopic Evaluation of Swallowing, or FEES. This can also be called nasoendoscopy. We can go into the patient's room. We use a small camera that goes into the patient's nose and looks down on that larynx, like we saw a picture in part 1. And we give them things to eat and drink that are dyed blue so we can see where they're going. Both tests, both instrumental assessments, are very good at identifying aspiration and penetration. Penetration is when food or liquid starts to go towards the airway but does not make it past the vocal cords. Aspiration is when that food and liquid goes past the vocal cords into the trachea. And we'll be seeing examples of that from both of these tests. They do have pros and cons, but they are both considered excellent, safe, objective measures in diagnosing dysphagia. So now let's take a look at a couple of videos from a video fluoroscopic study. So again, for a little anatomy review, this is going to be a side view of the person's left side of the face. And so we're going to have the lips, kind of this soft gray right here, the chin, that hyoid bone, and we'll watch that go up and out, should be ending up right around here. The epiglottis, that's going to fold over this part of the airway. Vocal folds are right around here, leading into the trachea. And the esophagus is going to be right behind that. And here is also that soft palate, so we can watch that raise, and we'll watch it through a couple of times in real time and then go frame by frame. All right, so that's just one swallow looping over and over again. So let's take a look at the anatomy and physiology of frame by frame swallow. So we're going to go frame by frame, and we're going to watch this soft palate raise up to meet that back of that pharyngeal wall, which it's doing now. And what's happening is a little bit of that liquid is getting in towards this airway, and this is what we call penetration. And you can see it's not going to the vocal cord, it's not going down the trachea, it's actually coming back out. Now, why did that happen? Well, as you can see, when this hyoid bone goes up and out, it's not going as forward as it should. And therefore, this epiglottis, you can see it's still in the upright position. That means it's not really protecting this airway as well as it should. There are also some other physiological things going on. The larynx is not raising up enough to shut off this area as well. So there's a couple things that are happening, but as you can see, that epiglottis never fully inverts. It's still, that tip of it's still up, not protecting that airway. So again, one more time in real time. Just a little bit goes towards the airway, comes back out. This next video, we'll see a patient who aspirates. Okay, so let's go back. And we'll go frame by frame with this one too. I'll go back a little bit. Again, we see that hyoid bone and that epiglottis, larynx, and then towards the esophagus. I'll wait till he swallows. He starts to swallow there. And because of his reduced control, he lets some of the liquid go into this airway. These are hitting the vocal cords right now. As you can see, they're that horizontal line, meaning that the vocal cords got splashed by barium. And as we go, we see that liquid, before the swallow even starts, it's going into the trachea. And now he swallows, which even adds a little bit more barium into the larynx and into the trachea. And you can see that streaming go right down towards his lungs. That happened because of that incoordination, and we'll watch that again. So as he swallows, that liquid goes into the airway before he has a chance, before that reflex kicks in. And then he swallows, but it's too late. The liquid's already in his trachea. So those are two examples of a video fluoroscopy study, one penetration, one aspiration. So let's look at a couple of flexible endoscopic evaluation of swallow studies. Here's the first clip. We'll play this in real time once and then see what happens in a slow down version as well.
With 3/4 teaspoon second trial. Try to hold your head real still.
And for anatomy again, this part is the back of the tongue going down the epiglottis that's going to fold over and should try to protect this airway. The vocal folds right here, the arytenoid cartilages that close together that help the vocal folds close together. And then the esophagus is going to be behind it.
That's it. Remember that if you need to cough or clear your throat or swallow again, you do what.
All right.
Thick liquid, 3/4
So what happened there?
teaspoon second
When this
trial.
person started
Try to hold your head real still, Miss Carter.
to drink,
That's it.
they lost control of the liquid that was in their mouth. And again, what we saw kind of on the last video of the video fluoroscopy happened here too. This time it didn't go through the vocal folds, so this is what we would call penetration.
Real still, Miss Carter.
And that right there. And so let's go. So this liquid just went over the back of the tongue a little bit too fast, hit those vocal cords, which then immediately slapped shut to try to protect that trachea. And it looked like it did a good job, but that's what a loss of bolus control looks like and penetration on a fees. And thankfully it looked like everything, there's still a little bit on the vocal folds, but nothing went through. So let's take a look at what happens when some weakness occurs.
Okay, so let's do half teaspoon applesauce. Okay, here you go.
So that's applesauce. And this is what it looks like when the back of the tongue is weak. It's not pushing the food, the applesauce, back enough. And also that posterior pharyngeal wall is not helping squeeze it down. And so there's that residue that's remaining in what we call the vallecular space or the vallecula.
I mean, I can feel that there's, you know.
So that's primarily due to back of tongue weakness.
Big drink. And applesauce is next.
And it's a little hard to tell in this video, but you can see that there's a little bit of that green on that first tracheal ring. And so we'll go watch that again. So if you look down there right now, there is no residue on that tracheal ring, but right after this swallow,
Big drink. And good. And applesauce is next.
and there it is, that green. So a very clear example of aspiration. So we saw a couple of examples of what dysphagia looks like under video fluoroscopy and under FEES. And also the possible causes of that, such as incoordination, swallow delay, or weakness causing residue. So what can we do to help that swallow out? Well, we have two broad categories, the first one being compensatory techniques, and the second one being rehabilitative techniques. In the first category, we can change the food and liquid. We can make the food a little bit softer if somebody's having difficulty with their oral phase, they're chewing or keeping food together cohesively in the mouth. We can even make it a puree texture that there's no chewing required at all, but we do have to understand that there are significant quality of life changes that can occur if we do make that change or recommendation. Similarly with liquid, we can add a thickening agent that helps with the swallow delay. If liquid is going too quickly into the pharynx, we can help slow it down and give the swallow reflex time to kick in and keep that swallow safe. We can also change the posture of the individual. If somebody had a stroke on their left-hand side and their right side of their pharynx is weak, we can have what's called a head turn to the right, which shuts off this bad side and lets the food and liquid go down the stronger side. We also have something called a chin tuck, which helps open the vallecula, that space before the epiglottis, and doing that gives the food and liquid a time to sit there and go around instead of going into the airway or over the epiglottis. We only recommend postural changes after doing a video fluoroscopy or a FEES study because we want to make sure that they work before recommending them to a patient. Sometimes these techniques can actually cause aspiration, so it's very important to, whenever we're recommending exercises or postural techniques, or even swallow pattern changes, which we will talk about, that we want to see it under an instrumental assessment before blindly recommending it. So swallow patterns. We talked in part one about the typical respiratory swallow pattern, which is exhaling a little bit, swallowing, and then exhaling the entire way. We can use that to help teach a little bit safer of a swallow. If we have somebody put food in their mouth, hold their breath tighter than they normally would, swallow, and then give a big cough and swallow again. That's called the supraglottic swallow. And what that does is that uses that vocal folds being together and then adding a cough after the swallow to expel anything that might have gone towards or in the airway. And there are more postures and more swallow pattern changes that we won't be discussing today, but just to give you a few examples. We also have rehabilitative techniques. These are typically in the form of dysphagia exercises. And although there are a long list of dysphagia exercises, many of them are not well researched. Before speech-language pathologists got as involved as they are now in dysphagia therapy, we weren't as well backed by science. So thankfully, as we become more of the experts in dysphagia, we are having really good research studies and good science to back up our ideas and our techniques. These two techniques, which I'll discuss briefly, have good research behind them and are very promising in the field of dysphagia. The first one is EMST, or expiratory muscle strength training. This, as the name implies, helps the muscles of expiration. This does two things. The main thing is it helps out that post-swallow exhalation. So it can make that stronger, so when you exhale after the swallow, there's more force to blow anything out of that airway that might have gotten down there. Also, while doing these exercises, it does have an effect on the muscles of the swallow themselves, and so they get stronger, so there's a little bit more force as well. Again, good promising research for this technique, especially with individuals with Parkinson's. The second technique is called the chin tuck against resistance, or the sitar. This is when there is resistance when you are trying to put your head down. It can be done with your fist or with the contraption here that they are now marketing. What this does is it engages a group of muscles called the suprahyoids. And those muscles are what help pull and elevate the hyoid bone up and out. And so if we do see that hyoid bone is not moving up and out far enough, maybe causing the epiglottis not to fold over as fully as it should, this is an excellent and well-researched technique to engage and strengthen those hyoid muscles to help strengthen that hyoid movement and hopefully epiglottic inversion. Again, there are many other techniques and exercises that we use, but just wanted to show a couple of really good, well-researched examples. In summary of the lecture, swallowing is complex. We talked about the 5 stages of the swallow, and in particular the pharyngeal stage, which has a number of structures that need to move almost simultaneously within 1 second to keep the airway safe while the bolus transfers from the oral cavity into the esophagus. Adding to the complexity is the cognitive and emotional aspect of swallowing. The impact of dysphagia is threefold. We have the psychosocial aspect, which includes the social isolation, the fear and anxiety of eating, and even hopelessness. There is the medical aspect that includes aspiration and aspiration pneumonia and choking, but also includes how someone gets their medication. The last one is the financial aspect that increases healthcare costs and also costs to the individual and their loved ones. Dysphagia has multiple etiologies, so there's a lot of causes for dysphagia. Not just the typical ones like stroke or neurodegenerative diseases, but something simple as infections or side effects from medication can cause dysphagia. We talked about the speech-language pathologist's increasing role in the care of individuals with dysphagia. I know going into the ICU now, it's a wonderful thing to be a part of the medical team, talking with trauma doctors, neurologists, dietitians, respiratory therapists. We are a part of that medical team, and we really do get to make a huge difference in individuals' lives. And lastly, we talked about the diagnostic and intervention process that speech-language pathologists go through to diagnose and treat individuals with dysphagia. Thank you so much for watching this lecture. I had fun making it. I'm sorry I couldn't be there in person for this lecture, but circumstances as they are. But I hope you enjoyed it. I hope you found it interesting, and I hope you learned something. If you have any questions regarding dysphagia or speech pathology in the medical setting, feel free to email me. I'd be happy to correspond over email or even set up a Zoom meeting if you would like to chat over that. Thank you again, and have a great rest of your semester.